Good morning, everybody. It's an honor speaking this year again for the symposium. As Dr. Saeed said, I'm going to be talking about cardiac neuro ablation. Okay, no disclosures from my part. So as an introduction, an abnormal autonomic activity may play a critical role in the occurrence of clinical bradyarrhythmias, as we know, such as vasovagal syncope, sinus node dysfunction, and functional AV block. In cases of symptomatic and refractory vagal-induced bradyarrhythmias, sometimes pacemakers play a role when they're very severe, and they're necessary to prevent these bradycardic episodes. Now, the basis of my talk will be talking about the modification of the cardiac autonomic innervation to the heart by radiofrequency ablation of the ganglionated plexi. This is called cardiac neuro ablation. So this will be talking about. And doing this procedure may reduce the impact of hypervagatonia on the heart. So just talking a little bit about what vasovagal syncope is. It is the most common type of syncope and is characterized by an abrupt dysregulation of the autonomic nervous system to maintain adequate blood flow to the brain, and that way, or cerebral perfusion. That way, if you don't have enough, obviously you end up passing out. So there's roughly three different types of vasovagal syncope. There is the more cardioinhibitory type, which is led more by a bradycardia. Vasodepressor type, which is more a drop in blood pressure only. And there's the mixed type, which is kind of the double whammy, both of them, blood pressure and heart rate going down. So the type of vasovagal syncope that we're kind of targeting with this is mainly the cardioinhibitory type and a little bit the mixed type that has a little bit more of the bradycardia arm being a little more prominent. So we basically try to intervene in the aspect where there's a parasympathetic overactivity causing that bradycardia or cardioinhibitory type of syncope. And when you have the vasodepressor type, it's mainly a sympathetic withdrawal. So our intervention to a parasympathetic ablation wouldn't really help a lot. So in theory, in vasovagal syncope, cardiac neuroablation works to prevent vagal efferent arm of the reflex arc in the cardioinhibitory type, or mixed, as we said, with a predominant cardioinhibitory response in the mixed type. So now talking about specifically sinus node dysfunction, it is most often related to age-dependent progressive fibrosis of the sinus nodal tissue or the surrounding atrial myocardium. It has a lot to do with, tachybrady syndrome, when you've had long-standing tachyarrhythmias that then kind of make your sinus node lazy and fibrosed. And the most important part of the patient selection for CNA is the discrimination. If, is it really or vagal mediated, or is it there already some kind of sinus node dysfunction intrinsic to the sinus node? So those wouldn't be good candidates, and we'll talk about that a little more. So how do you distinguish if this is a dysfunctional sinus node, a fibrosed sinus node, an older sinus node? Obviously, age is important, but there's when you're in the fence, like, well, this is a young patient, but I'm not sure if they're going to benefit from denervating the heart. You can do some testing, like you can give some atropine. And if your atropine ends up accelerating your sinus node and speeding up your AV conduction, that means that you have a healthy conduction system. And that kind of confirms that whatever bradycardia you're having is mediated mainly by an increased vagal tone. So the way to do it, there's some protocols, but just roughly 0.04 milligrams per kilogram under continuous ECG recording. You give some atropine, and you just want to see a response of the sinus rate going up by more than 25% or more than 90 beats per minute in the first 15 minutes of the infusion. that would be considered a positive response. That would be considered something that would benefit from cardiac neuroablation. And if there's no response, then that sinus node is sick, right? In terms of AV block, it is, again, usually caused by intrinsic disease as well. But when you do have already intrinsic disease of the AV node, your symptoms when you're going to pass out typically are less than 5 seconds. This is a more of a sudden situation. If you're going to end up having syncope because of AV block, AV dysfunction. And the vagal-induced AV block or functional AV block, this one gives you a little bit of time, right? More than 5 seconds, you have more symptoms, more prodromal symptoms, and you kind of know that you're going to pass out, and then there you go, right? And you typically see a slowing of the sinus rate first, and then you got your AV block. And also you can, do that atropine challenge in those cases to see if it's purely vagally mediated. So you get a patient with syncope. So obviously you want to get a good history of how that syncope happened. Again, how did they have prodromal symptoms? And, you get a sense of how that syncope is sounding. Is it arrhythmic? What happened? You want to do, of course, your physical examination. You want to check your blood pressure, supine and standing. ECG, obviously, sometimes we go to tilt table test, and the use for tilt table test in this case is mainly to determine what type of syncope we're dealing with. We talked about the type that is cardioinhibitory, the vasodepressor, and the mixed one. So a tilt table test gives you more of an idea of what's going on, what drives what, right? And of course, once you don't get a good answer for anything, loop recorders are also a good tool to have. So again, just talking about, you get a patient with your syncope, you do the steps that we talked about. Once we go to the tilt table testing step, we determine what type of syncope we're dealing with if, of course, our test is positive. And we see here that on the side of the vasodepressor, that's where our midodrine, our fluorocortisone, those types of medications will help. Of course, we're going to advise to everybody all these conservative measures of compression stockings, increased fluids, electrolyte, salt, all those things. That's assuming that we already did all of this. We have the mixed type that can also respond to some of these medications. But then when we have the cardioinhibitory type, that we get these patients with this crazy pauses in their monitors and all these things, we're kind of pushed to see if they're going to need a pacemaker or what. I mean, I've had patients that have had seizures because they've had like crazy pauses of like 10 seconds and stuff. So you kind of have to do something about it. And these are young patients, that can have that degree of cardioinhibitory responses. So this is kind of on that patient population, younger patients, those are the ones that are going to benefit from this type of therapy. Then we have the age group of more than 60 years old. You kind of have to assume that there's already some fibrosis, there's some dysfunction of their conduction system. So those wouldn't be good candidates. I wouldn't consider doing any of this on older patients. But then you have the 40 to 60 range. I think that's a patient population where it's worth doing that atropine challenge, investigating a little more what drives what, doing that tilt table, getting a little more information to see if it's going to be worth doing this type of therapy with cardiac neuroablation. So, well, that's again more what we talked about of the types of syncope that we can unmask or kind of study a little further with a tilt table test. We can tell if it's a mixed, type 1 is the mixed one. And then we've got the 2A cardioinhibitory without systole. Then there's a type 2B, there's a cardioinhibitory with asystole. And the type 3, which is the one that we're not going to be touching, is the vasodepressor one. So the role of loop recorders here, more than a third of patients end up completely without an explanation of why they're passing out. When the tilt table test is negative, everything is, and they're still kind of having syncope, these are the patients you want to consider putting a loop recorder in just to get more information on what's going on when they actually pass out. So now, and getting into the cardiac neuroablation part of things, there are a lot of unknowns. So obviously, this is not a thing that we commonly do every day. This is not our bread and butter. This is just a tool we should know about and something that we should further study, I think, because at least in my experience, I've seen some benefit, and I'll talk you through it here. So again, as I said, a lot of unknowns. We don't know what is the best method to identify the ganglionated plexi during the ablation. The best ablation strategy, because again, these are not well-studied, a well-studied strategy. Complete or partial denervation, what's better, doing just partial or complete, and the selection of the suitable candidates. So on patient selection, again, as we said, the ideal patient is going to be your young patient, your patient that has mostly cardioinhibitory response or syncope, and basically if you see functional AV block or sinus bradycardia, you want to challenge these patients with atropine and make sure that they respond to the atropine. And then from there, determine that if they're going to benefit from some either partial or complete denervation of their heart. And when I say younger, we're talking about less than 50 years old. There's been many studies, not many studies, again, there are not many studies, but the ones that they exist, they're all observation. There was just one that was just published by Pristowski last year that is the only randomized control trial. And it's a small patient population. There's just like 48 patients or so, but they had very good, results. This is a 2-year follow-up, and they had a significant decrease in syncope of about, recurrent syncope was 8% on the arm that they did do the CNA, and 54% on the patients that they just did medications and conservative, measures. So, I mean, there's and all of the observational ones also have extremely good results on proceeding with cardiac neuroablation. Now, moving forward here, that's the only one that exists right now. So now, more onto diving a little bit more on the procedure side of things. So our ganglionated plexi are located in the epicardial atrial fat pads, and they do connect the preganglionic and postganglionic nerve fibers to affect the heart rate, and atrial and ventricular refractoriness and cardiac function. So they're typically located out here in the epicardial aspect and the epicardial fat. And RF energy can be transmitted easily to these GPs via the atrium from the endocardial aspect of where we already ablate, a lot of our arrhythmias. And that's how we've kind of known that we've affected it. A lot of the times, the EPs around here won't let me lie here, but when we are ablating atrial fibrillation, for example, some of the areas cross where some GPs exist, and we see this like extreme vagal responses when we're ablating with bradycardia, even asystole at times. So GPs, of course, we can ablate them from the left atrium and the right atrium. And, there's anatomic approaches, of course. I mean, if you look at all of these anatomic places, that's the places where you want to go and put your catheters and look for if you do have certain characteristics that we look at. So again, this is just a different, areas that we kind of target, and this is just over a lot of these observational studies that they've done these maps in kind of where they've found the good target areas. So what you want to see, and I'll talk a little bit more about this, you want to see this very fractionated signals in the areas where you think anatomically you're going to find ganglionated plexi. And there's certain GPs that you want to target if you want to modulate more your sinus node or your AV node. So the more the inferior ones are more geared to the AV node, and the superior ones in both atria are more geared to the sinus node. And if you have both and you want to take all of them, well, you take all of them, right? But so now that's anatomically kind of where we want to go and check if there's vagal response or if you have those fractionated signals, as I said, anatomically guided. But there's other ways to tell, is there really a GP there or not? You can do what is called high frequency stimulation. It's pretty aggressive. You go in with a catheter, you say, oh, maybe I have a GP here, I'm not sure. You do like very quick, high frequency stimulation in there. The problem with that is that you can put your patients in atrial fibrillation because of the super fast pacing. So I don't do it. But I mean, it's been described in these observational studies that we talked about. And then this is how I've been doing things and working with my mapping system. We've communicated on to how are we gonna want to approach where we're gonna ablate or where we're gonna determine that the GPs are. And my method is with the spectral guided method, which is targeting those fractionated. And by fractionated, it's not just like crunchy and ugly. You want to see at least 4 components, and components being up, down in that signal. Normally with your smooth atrial, conduction, when there's no GPs, you'll see just like a sharp signal, maybe 1 or 2 components and high voltage ones. That's not what you want to target. You want to target kind of fractionated multiple components to the signal, and anatomically where you think there's going to be GPs. Now, you can think, oh, that's a good one, but it could be scarred too. So you want to make sure, and kind of the cutoff they did look at for the voltage, you want to make sure that the voltage is higher than 0.7 millivolts. So it's crunchy and a little bit higher voltage, or multi component signal, and higher voltage. If you see lower voltage than 0.7 and it's not quite where a GP should be, then it's probably scar, right? So you kind of move away from that. You want to target the areas that have all of those characteristics. So, and the reason, and as I said, like where you have high innervation in that endocardial aspect where you're mapping, basically the conduction in that area is it's not as smooth as where you don't have that high innervation or rich innervation. That's why your signal is going to be fractionated, slower area of slower conduction, higher amplitude that a scar would give you. And they're actually called AF nests. And we know also that this, high vagal tone has a lot to do also with atrial fibrillation in these areas of slow conduction in the atrium. So those are the targets that you want to go and ablate, basically. This is just some of my own patients that I just kind of take. The pictures are terrible, but you see a very kind of fractionated, multi-component, signal in there. And again, this is just talking about, okay, you target your GPs anatomically with fractionated areas, or if you want to do high frequency stimulation, however you want to determine, you ablate. What are going to be your endpoints right there, your acute endpoints, right? What do you want to see? A lot of the times you would ideally want to see a profound vagal response when you're actually ablating. You want to see asystole or slowing of the heart rate or AV block in the areas where you think there's going to be a GP. Now, at the end, you also want to see an increase in the heart rate of the patient. And basically, as I said already, when we are doing atrial fibrillation ablation, we take a lot of these GPs without knowing. And a lot of the times the patients, when they come to follow up, they say, oh, but now my heart rate is 90, or now my heart rate is a little higher. I used to have a heart rate of 60 or something. And this is the reason why. So, but if you're really just targeting the GPs, you want to see that increase in heart rate. There's going to be a shortening of the PR. You can challenge the patient with atropine at the end again, and you want to see that response abolished. So there are many things, and in all the studies that we looked at that have been done, they kind of target different things, and some of them have challenges with atropine. Some of them just look at the heart rate, and obviously the follow-up is going to be important. Is the patient still passing out or not, right? I mean, that's going to be your primary endpoint in the future. Now, most of these observational studies that we showed, and the one that was just published, the randomized control trial one, the most follow-up is about 2 years. And at 2 years, the results that I talked about, they've been very good. I did not find any other studies that have larger or longer follow-up than 2 years. So yeah, well, this is just pretty much what I said about the endpoints. And this is one of my own case, and this was the first CNA case that I did. And I presented today because I just saw the patient last week, and this is the first one that I have a 2-year follow-up on. So this patient was sent to me for consideration of pacemaker. He's 45 years old. This was 2 years ago, but he was also having flutter and fibrillation. So I was already going to take him for ablation anyways. I mean, obviously therapies on him were very limited because of the profound bradycardia, AV block, and obviously asystole that you can see right there in the midst of flutter. And so we chatted about this. I said, listen, I've never done this, but I can try and see, and we can see if that works. If it doesn't, I'll just put a pacemaker on you, right? I mean, and the patient was like, I absolutely don't want a pacemaker. He was a, athlete. He did not want to even remotely consider pacemaker, but he was having syncope and obviously palpitations as well from the periods he went into atrial fibrillation. So we went in there, I did the PVI, but I also targeted, as we said, those GPs, got great results, acute endpoints on the increase of heart rate, PR was shorter, all the things, atropine, and, at least acutely, I said, okay, so we'll see what happens. I did put on the ones that I've done, and I started with this one, I said, I'm gonna have to put a lubricator on this guy because I wanna make sure, at least for my follow-up. I didn't see in any of the studies that they put lubricators. They actually just do holters or monitors every so often, 3 months, 6 months, 12 months. On the ones that I've done, I put lubricators, obviously with the consent of the patient, just to make sure I'm not missing anything. So I did both, again, right atrium and left atrium in this case. And this is the EKG from when I first saw the patient. This was his heart rate, which was 76. His PR was 186. And at follow-up, after the CNA ablation, heart rate was 99 and PR was 160. Now, did he like having a heart rate of 99? No. So I put him on propranolol for about 6 months. He did great, and of course he had the lubricator. He did very good. The first 6 months, he stayed on the very low dose inderal propranolol, and then we stopped it, and his heart rate kind of settled in the 80s, and he's doing good, right? Now, this is his lubricator check last week. 0 events, 0 bradycardia, 0 AFib, 0 anything. And this is a 2-year follow-up of my first CNA. The other ones that I've done after that, of course, I don't have a 2-year follow-up yet on, but the loop recorders look clean. So that's nice to see. Hopefully, I get enough patients to now really kind of publish a formal, case series. But so far, so good. And that is it.